Hello, everybody. I'm Ron Waxman. This is a CRT on the web, and we're doing the COVID-19 series. And I have with me Dr. Stephen Bailey, who is the chairman of medicine at LSU in Louisiana. Welcome, Steve.
Welcome, Ron. Thank you for the opportunity. I trust that you're doing well.
Thank you, and hopefully the same for you. And you look good, so that's a good sign. And we heard a lot going on in Louisiana. You actually was one of the hot spot, and it seems that it's been under control. So you have a very large institution. Can you tell us a little bit where you're standing right now? How did you cope with it in the first days of the pandemic in your institution?
Well, you know, it's very interesting because we cover a large geographic area. There's the north part where Shreveport is located 5.5 hours south all the way down to New Orleans, where sister institutions, LSU New Orleans and Oxnard are located. We have seen really gradients across our state about what this looks like and what the impact has been. I think everybody's aware of the early and very high penetrance of COVID-19 in New Orleans in particular, where every hospital essentially was COVID, much like New Orleans, much like other centers. We were a little later in that and actually had the ability here to learn from what was occurring and the option of preparing with some of the expansions and ICU capabilities, being able to have appropriate amounts of ventilators, PPEs, et cetera. So it's a contrast in terms of what's occurred.
Yes, so I think one thing which was remarkable maybe that the expectation, at least for those who are in the Northeast after what happened in New York, seems that you're going to follow the same pattern that happened in New York City because of the dense of population in New Orleans. And but it looks like it's immediately came under some control. So is there anything that you can attribute to the fact that it was not spiking to those? I mean, the expectation here was that it's going to be much worse than what it really happened.
So I think that there were a large group of people that worked collaboratively together early. And so that was, you know, one of the things that we faced with all of this is being able to understand what was happening, not just at an institution, but all of them, and look at collaborations between institutions to address that. Similarly, we had a very early decision to engage in some of the mitigations, the distancing, other things. Not early enough, as everybody has heard, the annual February celebrations of Mardi Gras held throughout the state clearly were drivers of this. But I think systems of care were important. Oxnard is an institution that has a large number of facilities that really interact proactively, and so they share information. And again, I think that sharing across institutions, along with the mitigation in communities, was part of the secret to that.
Yeah, that's good to hear because I think it's all about care. But on the other hand, you do have also a lot of minorities and people who actually not in the best shape of care. Again, somehow it looks like that the numbers of mortality were not going high. So would you say that this is different, the way that you attribute this to the healthcare providers in your organization, detecting early the patients, or maybe this is a wrong conception?
Well, clearly we, as you and others have had a very large impact on minorities. We saw a disproportionate mortality in individuals of color. And I think that that disadvantaged, in terms of care, was a big part of that. We were lagging like everyone else in testing, so I really can't attribute that change to really early testing or broader testing. We're doing that now, and I think we're being able to utilize that. So I think one of the questions that is important that we don't know, that we're actively looking at through our viral labs particularly our academic viral labs, is to see whether or not there are variations based upon strains of virus. Perhaps what we had here was a different strain that manifests itself differently. Our research lab is beginning to give us glimpses of that information, that viral load and severity of symptoms seems to vary, and that what we're seeing may not be exactly what was on the East Coast or the West Coast for that matter.
Yeah, I mean, I thought about the viral load that may be different because one of the things that's striking is that you look at the asymptomatic, they sometimes have a huge viral load that they shed
Yeah.
versus those who are already in the intensive care unit with cytokine storm and they actually don't shed much viral load. And that, but one thing that I wanted to allude to, the sensitivity of the virus to the weather, and obviously in Louisiana, the temperature are by few degrees higher than what we have in the Northeast. So is there any thoughts that high temperature, warm weather, more humidity is weakening the virus and maybe slowing the infection rate? I mean, is there any signs in the local experts that attribute it to the weather?
Well, I think we all were hopeful. Folks had talked about that in other COVID viruses about perhaps more sensitivity. I will say so far, I don't think we're seeing that, at least in our local statistics and numbers. Um, and so, obviously, we haven't really gotten to sustained heat, sustained humidity yet. So I don't think we have a good enough sense in a population to really know the answer to that. We'll cross our fingers and hope that we see that. Certainly, any benefit we can see is welcome.
Yeah, because when I look at the map in the US, I see Florida, I see Louisiana, which you would expect to have higher. Hopefully, you're happy they are not. But what's common on both of those states? I mean, the governor is always going to take it to their credit. I mean, I'm sure that they're going to attribute everything to the measures that they made. But if you look across the board, you would like to look for some other factors, and that's why I brought that weather issue. Tell me, Steve, what is that you're doing right now and what you cannot do? I mean, are you still not doing elective cases in your hospital, or you're starting to infiltrate them carefully into the system since you have more testing capabilities?
And so we really have benefited from broader testing capabilities. We have not only commercial labs through our clinical locations, but research opportunities through our research viral lab. And so we're currently not limited by testing. We've actually done 3D printing of nasal swabs through our biomedical group. So we actually have swabs, which has been a rate limiting step. I think based upon where we were at, we have a approval here in the state to begin doing elective procedures, which was effective just 2 days ago. Every patient that's coming in is being tested, not just symptomatically questioned with temperatures, but we actually are proactively doing viral swabs to make sure they don't have any evidence of active viral load. And we're also beginning now to extend the antibody testing. So we're getting a broader picture of that. We're doing that 72 hours roughly ahead of when patients come in, obviously rapid tests for those that are more urgent. So we are readdressing those patients that unfortunately have been deferred because of COVID. And of course, for cardiovascular patients, we understand that deferring care may convey and likely does convey an increased risk in those patients that may be this, we don't know how much that adds in the setting of COVID, but we want to make sure that they're appropriately addressed.
That's true for all surgeries like orthopedic, ENT, dermatology, or there is like or you stagger those based on, risk to get infected.
Yes.
ENT maybe less than podiatrists, etc.
Well, we talked about that extensively among the groups. We involved our infectious disease and infectious control folks, and it was our best assessment, right or wrong, we'll be a test site for that, that in fact, with the testing protocols that we had in place, with patient monitoring, because we also are going to be monitoring the patients afterwards, that we were going to go ahead and broadly reopen our care so that podiatry or ENT, whether you needed a TEE or endoscopy, that all of those would be made available for patients that needed procedures.
So you're living in a world that everybody expecting to have almost unlimited access to testing, and I wonder if you testing the patients that's supposed to come to elective, that makes sense. Are you going to do it also for one of their family member that want to escort them? I know that many patients are like to be escorted, especially for more complex procedure, or this is limited just for the patients?
So that's an important point. Currently, we've made the decision to start with step one, which is just having that patient, family members, are available to be, close by, but not into, we still have a closed hospital for that. We've gotten a lot of patients who, have been very concerned about having procedures without family members present. But I think for now, we're going to go the first step, see how that goes, and as we have further expansion, we'll be able to increase that to include family members.
One other concern is that patients still going to be afraid to come to the hospital as long as other COVID patients are um, being hospitalized. And we have been trying to call to our patient, and they said, well, why don't we defer it to July, August, when you're not going to have any COVID patients? So it is definitely a concern. So did you guys thought about, in your system, you have multiple hospitals, to dedicate some hospital just to COVID only, if you have the capacity, and then to have COVID-free hospitals to address this concern of patients?
Well, I think that's one of the most important questions. We've spent 6 weeks, 8 weeks telling people that you shouldn't go to the hospital, that they shouldn't seek care, and now we're turning around and expecting within a couple of days that the message gets shifted. And not surprising, healthcare providers and patients are confused. I think the point you bring up is great. In our facility, again, we've had the luxury to uh, begin to decompress so that we have COVID positive units that actually are separate from our other units. So we can provide some assurance that you're not going to be co-housed in an area that is COVID positive. But I think Oxnard I'll bring up again, because in their system, they have done exactly that. I was talking to Chris White yesterday, and what they have done is they have moved all of their COVID patients out of a number of hospitals into a single facility now, and then coalesced all the COVIDs there so that they can begin to open up the other facilities, provide care through there, and give assurances to patients that they're going to have great care. And by concentrating on the COVID patients where they are, I think that also increases the level of care that those very sick patients are going to get.
I think that's a thought that goes circulated in many places, but I'm really worried that if we're not going to approach the patients and explain them that they do harm to themselves by not coming to the hospital, we're going to lose a lot more patients from that than we'll lose them from the COVID-19. And one of the issues here that we are struggling right now is to send the right message and not to scare them. So many have been implemented telehealth. And your technology and your technology, we've been doing telehealth or all those gadgets years and years ago, but now it got some more traction because of the distance and the fact that patients couldn't come to the hospital. So my question to you is twofold. First, did you implement it really um, telehealth in your system, something like a serious program or solid program like that? And what is the feedback that you get from that? Is it really working? Is it really substituting the personal visit in the office? And I don't know, procedures, obviously we cannot do with telehealth, but what can you tell us from your hospital experience implementing or not implementing telehealth?
So we were in the process of expanding telehealth, although we had planned to really have a broader platform about 18 months from now. like many other things, that got compressed into a very short time frame, and we went from about 3 or 4% of our visits 8 weeks, 9 weeks ago to be telehealth, to nearly 40% of those visits and increasing. I think that as physicians have had trouble adjusting to it, initially it was a bit of an adjustment for patients. We worked very hard. So for patients who still wanted to come to the clinic, we actually walked them through how to do the log on and telehealth visits. So the next time they needed a visit, they were comfortable on how to log on. Many of our patients aren't technology champions. And it's interesting, the satisfaction rates, because we're all measuring that. And the likelihood of someone giving you a rating for satisfaction have been, tremendous. They've gone up, both their satisfaction and the frequency that they answer the questions. And I think they went up at a level that I was surprised at. There's not a substitute for, a sick patient with valvular disease or, a cardiomyopathy seeing a doctor. And so we still see that in our cardiology practice appropriately. But for many of the patients, that's important. The other is how far away or how long people have to drive or whether they'll drive into the big city. And so the interest in people of not having to drive distances or being uncomfortable driving has really helped with that acceptance as well. So for us, it's been a positive. I'm sure that we see an enduring change now as we go forward and are looking to implement other personal health devices into that and into that broader platform.
Yeah, no, I share your expectation. Things will be changed, obviously. My only concern with telehealth that it will keep the patients away from the hospital. So I think this message still has to be, you still have to come to hospital if you need procedure, if you have chest pain. It's not the iPad or the computer not going to keep you healthy by itself. It's just another way of communication.
Well, I know you have seen it, as we have all seen, a decrease in the presentation with STEMI and stroke with all of this. I think our messaging, one of the metrics I use of success is, as we have reached out into our community, we actually are going into the community and on vans and into community centers and testing individuals in our community. And what we've seen just in the last several days is now an increase in individuals seeking care for stroke and heart attacks here. So I believe that the message that we're trying to deliver that you're describing is one that we're getting some success and traction with doing.
Yeah, almost like to see on the big billboards to the patients, don't forget to come to the hospital if you have chest pain, if you feel something wrong. I mean, call your doctor, just don't keep it at home. Finally, you're a wise man, you've seen a lot. How do you see us all getting out of this situation right now? And how fast do you think it's going to happen?
Well, I wish I knew the answer to that question. I think that what we're seeing is something that is going to continue with us for a while, right? I think we've gotten through this area where we've had a peak, but I don't know about your facility, but the facilities here are all seeing this background, constant number of individuals. The problem is that those that get COVID are ill. They're in the hospital longer. They take a longer time to recover. They need more rehabilitation afterwards. And so hospital bed occupation, I think, is going to remain at an important background piece. This thing is sneaky. This thing infects a lot of people. And I think, we don't have a lot of reference, but if we look back in 1918, that was not 1918. It was really through the summer of 1919. I think we'll see much the same here, that, we will establish a new baseline. But until we have better testing tools, and particularly until we have vaccines, I think this is going to be an important part of care and how we address that and how we test patients. So it's our new normal.
Yeah, we need to live with that, and we have to be creative and innovative and to find the silver lining, how to continue to function in the presence of the virus.
Well, and I think the innovation that you talk a little bit about that, but I think we're going to see that. it may not be a new filter for TAVR, but it may be in the arena of how we can have patients be alerted at home about a heart attack. Certainly at CRT Innovation Hub, that was one of the things that we talked about is, how we can help ourselves systematically in patients, be able to better tell this and maybe be able to give information instead of having to come to hospitals. So perhaps we'll hear more
Yeah,
about that at CRT.
it does open a lot of opportunities for innovation. I would say innovation should be now on steroids. And we are seeing it already in the testing, and we probably going to see it with a lot of other strategies. I mean, we really have to, I mean, it's only innovation that will take us out of this, or at least allow us to live with this new um, uh, virus. And I think we'll find a solution. It's like we always did, so there is no reason why I should do it now.
I think the other piece we're seeing is more international collaboration. And people are willing to work faster, work broader, and perhaps this will set the stage to eliminate some of the barriers that we all struggled with over time of really segmentation and segregation and not allowing access broadly to people as we were developing these things. So we'll look for a little lemonade out of all of these lemons.
And with that optimistic note, I think we should conclude this chat. First of all, I'm glad to see you're healthy and you fully control of the situation in Louisiana, and I can see only good things and news coming out of your state. And it was really nice chatting with you. So stay healthy, stay strong, and hope to see you in person soon.
Soon, and bonus salads. Good health. Thank you, Ron.
Thank you.